Assalamu alaikum wa rahmatullah, respected orthodontist, my dear friends and postgraduate students. Today, I, Dr. Junaid Khan, is very excited to start a series of lectures which will be mainly the educational videos which I will be broadcasting on my YouTube channel, and it will be on other social platforms also. So coming back to our first case, this is a patient who is 19 years old male and he is having a skeletal class 3 pattern. These are his photographs, extraoral as well as intraoral photographs. Here we can see that the patient is having a missing central incisor because of an accident. He lost his tooth, and these are the right buccal, left buccal and occlusal photographs. So these are the extraoral photographs where we have a normal wrist photograph and a smiling photograph. And now coming to the pre-treatment photographs, that we can see that the patient is having an incompetent lips, and he is having a nasolabial angle of 97°. And once we try to see his incisor display comes out to be 1 mm, and during smile, he is having a full crown display. And in this profile view, we can appreciate that most of the patients who are having a skeletally class 3 type of pattern, their maxilla is most of the times is hypoplastic. That's why the arc which we are seeing, the concave profile, which is here, we can see that the maxillary bones, they are hypoplastic, and this arc determines that the concavity where the mandible is a bit ahead than the maxilla. And we can see that the patient midline is concordant with the upper facial midline, but he is having a cross bite, and upper midline is concordant with the lower midline. We have in vertical dimensions, we have the cross bite in the right side of and we have a cross bite on the left side as well. And once we see the anterior posterior relationship, we can see that the canine are in class 3 and the molar on the right side are class 3, and the molar on the left side is having a gap distal to canine, and again they are the class 3. The arches are oval in shape, and we can see that the color which highlights that there is a lingual dumping of the posterior segment in the lower arch. And now, as we know that the cephalometrics, that is an aid for our diagnosis. So let's see on the skeletal basis what are the parameters, what are the readings for his bones. So his his SNA comes out to be 83°, and his SNB comes out to be 84. As we try to see the relationship of the maxillary bone with the mandible bone in with respect to the cranial base. So it comes out to be A and B of -1. So it is a skeletal class 3 pattern with orthognathic maxilla and prognathic mandible, which makes this case as a skeletally class 3. Then coming on to the vertically regarding the mandibular plane angle, if we see GOG into SN, it comes out to be 25°, which shows that in the vertical plane, it is a horizontal grower. Now coming back to the dental parameters, as we saw in the skeletal parameters, it's a skeletally class 3 case. As far as the dental parameters are concerned, when you try to see the upper inclination of central incisor, it comes out to be 35, and it says that it's a procline and forwardly positioned maxillary incisors. Similarly, for the lower incisors, it comes out to be 30°, and it says that's forwardly proclined lower incisors. The interesting part here is that mostly the class 3 patients are having the compensations, like the upper incisor get proclined and the lower incisor get retroclined. But in this case, there are no compensations in the lower arch, and the teeth are more towards proclined, not retroclined. So furthermore, when we try to see the IMPA, it comes out to be 99°, which is more than the normal. And the linear measurements are that the upper incisor and lower incisor are 10 mm ahead from the normal routine of 4 mm. So there is a anterior posterior linear dimension of 6 mm increase. When we try to see the soft tissues, if we check the S line, Steiner line, the lower lip is 5 mm ahead from the normal upper lip, which signifies that the lower jaw is skeletally class 3. Nasolabial angle is 97 degree, and so our inference is the lips are protrusive with obtuse nasolabial angle. This is the pre-treatment OPG of the patient, where we can see that the patient is having a missing central incisor, where we are using a riding pontic for that. And secondly, the yellow line signifies the class 3 molar relation, and the red line signifies that how much amount of distalization we will be done in the mandibular arch. So coming on to the diagnosis, we can say that we have the thing that we can extract the lower 2 premolars and we can settle the case. But I will ask you a question and you will just comment me on that why in this case we are not extracting the lower 2 premolars to settle this case, and why we are going for a skeletal anchorage. So now, as far as the diagnosis of this case is concerned, this is the case of a 19-year-old male patient with skeletal class 3 jaw relation on account of the maxilla is orthodontic and the mandible is prognathic, and the growth pattern is horizontal, and the molar relation is class 3, which is having a reverse overjet. Now coming on to the problem list, we have the proclined and forwardly placed lower incisor because there is no compensation. So this case is in a decompensated, it is in a decompensation. We have a reverse overjet, we have the concave profile, redundant lower lip, spacing in lower anterior, and importantly a functional mandibular shift. That's why once a person is having a functional mandibular shift, mostly in a case where you have a crossbite in anterior region, and in this case the patient tries to close his mouth to his right side, showing the mandibular deviation of 3 to 4 mm. But once we try to make his mandible in a centric relation, it shifts back to its left side. So this posterior crossbite is not the true crossbite which we can say. So what will be our objectives in this? So how we are going to treat this case? We need to attain a well-balanced straight soft tissue profile. That's number 1, because we have a concave profile. Number 2, we need to correct the crossbite because of the mandibular shift, which functional mandibular shift. Incisor proclination, which needs to be addressed. We have the spacing, lip incompetency, and correction of class 3 molar and class 3 canine relation on both sides. And of course, we have to restore his 2-1 by putting a 2-1. So how we are going to deal with the mechanics, and mechanics, which is one of the important part or the important tripod having diagnosis, mechanics, and treatment planning. So I started this case by putting a buccal shelf of dimension 2 cross 10 from Fav Anchor, for which I used this bone screws for whole arch distalization. This is the OPG which is showing the buccal shelf screws. And one important point which needs to be discussed here is that if we see in the third quadrant, the buccal shelf screw is on the mesial part of second molar. But once we see the right side buccal shelf screw, it's distal to the second molar, because most of the times once we see the oriental population from Japan, China, or other countries which are in the far east, they have a good amount of buccal shelf and a shallow buccal shelf, which is very good for putting the buccal shelf screw. But mostly the Indian population is having a buccal shelf which is very deep, and it's mostly on distal aspect of second molar. As we can see that it's mostly on the distal aspect of second molar. So on the left side I have put in the buccal shelf, and on the right side I have put more towards in the on the oblique ridge. And this is the right photograph showing that the buccal shelf, and here's the buccal shelf. And I have used the blue bite because we have the cross bite in the anterior region, so we need to raise the bite so we can take the mandible back and we can go for whole arch distalization. So this is showing the blue bite. And now coming on to the OPG here, we can see that this OPG, which is being shown on the screen, is at the time of debonding. Here we can see we have put an andosseous implant, and after that there is a lingual retainer being given to the patient. And the red line which was in the pre-treatment, here we can see that we have distalized the molar on the left side and on the right side by extracting the 3/8 and 4/8. So we have a good amount of distalization and distal tipping of the posterior teeth. Here we can see that we have attained a distalization of 3 to 4 mm, and here this is a debonding OPG of the patient, and similarly on the right side. And this patient came back to me after 2 years, so I just thought that I should document this case. So after 2 years, we can still appreciate that the lingual retainers are intact, and also we can see that the red line which are showing the amount of distalization which was at the time of debonding and which is present now, it is pretty on the safe side. Also, this is the pre-treatment, this is the debonding, and this is the 2-year follow-up. So at the time of pre-treatment, it was having a reverse overjet, and it was having an now after 2-year follow-up, we can appreciate a positive overjet, and the soft tissue are in a harmonious manner. This is the pre-treatment and the 2-year. So by saying this, we can say that the lower incisors have retroclined, or there is the change in the inclination from 99 to 85. It means a 14-degree inclination change. And the soft tissue, as we see the Steiner's line here, we can see that the lower lip was 3 to 4 mm out. Now it is just touching, or we can say it's just on the brim of this line. So this is a frontal photograph of the patient in the pre-treatment. This is at the time of debonding, and this is 2-year follow-up. And we can also see that once this patient came to us, that there was a soft tissue cant also in the pre-treatment, and after 2 years we can see that that cant has been addressed, because the functional shift and the proclination of lower and the lower jaw was proclined, or it was prognatic. So this is the smiling photograph in the pre-treatment. This is at the time of debonding, and this is after 2 years. We can see the confidence in smiling, and the quality of life has really changed for this patient. So these are the pre and the 2-year follow-up photographs. Then coming on to the 3/4 smile photograph at rest, this is the pre-treatment incompetent lips at the time of debonding, and then after 2 years, we can see the competency in the lips. This is the chain of photographs showing, and now see the smile here at the time of pre-treatment and at the time of debonding, and now after 2 years. And we can appreciate the glow on his face. And these are the lateral profile extraoral photographs. We can appreciate his lower jaw and his lips, and now after 2 years, how the patient is now. These are the intraoral photographs, pre-treatment, same debonding and 2-year follow-up. These are self-explanatory, showing the results. And we can see, even though there was a functional shift in the mandible, and it was almost 4 mm, but we have reached to 2 mm. These are the canine class 3 to class 1. This is the canine relation, which was class 3. Molar was super class 3, we can say, and now it is class 1 canine and class 1 molar. And on the left side also, we have class 3 to class 1. Even though after 2 years, we can see that still some amount of settling is going on in this patient, even it has not settled. Also, we can see that the tooth, besides being distalized, besides this whole arch distalization, there is also a distal tipping. These are the occlusal photographs where I have used a riding ponting, and here is the full cusp which we have given. So the problem list and the treatment objectives. Now we can check stepwise that whether we have attained it or not. And these are the intraoral photographs also regarding follow-ups. So the real results comes in the superimpositions. Once we try to superimpose the pre and the 2-year follow-up cases, this is the Nasion-Bayesian line of the rickets, where we try to see the growth axis, and even though the red signifies the post and the black the pre, even though not much of the changes in the symphysis, and this is the position of the maxilla of A point with respect to cranial base, not much of the changes, even though the molar has gone a 0.5 mesial. Yes, in the lower arch, we can appreciate that the molar has distalized 2 to 3 mm, and there is a lingual tipping of the lower incisors. And this is the soft tissue superimposition, where we can appreciate that the lower lip has got competency and the lower lip has got retracted by 3 to 4 mm. Now, this is a composite analysis where we can say not much of the changes, because this is an adult case. We don't expect miracles in this, because we don't have the growth where we can play with it, because now we have to go for a we can say camouflage or some compromise. So we can see that not of the much changes in the skeletal parameters, SNA, SNB. Yes, we have changed A and B from -1 to 0, and the lower incisor to mandibular plane is from 99 to 85, and lower incisor to NB from 9 mm to 4 mm, and yes, lower incisor to NB is from 30 to 15 degree. This is the thing at the potential which we have in whole arch distalization. Also, the soft tissue, we can see that the S line from 5 to 1 mm in the present stage. These are the pre and these are the 2-year follow-up cases of 2-year follow-up for this case. Also, now I want to ask you a question that in this case, as I ask you, one question will be that why we are not extracting the lower premolars in this case. The second question is that why what are the things we can do to customize the brackets once we are going for the whole arch distalization? What are the customization in the brackets which we can do? So these are the OPGs. Pre-treatment, debonding, and 2 years. So the last question which I want to ask you is that, besides the 2 questions which I asked, that why we are not retracting the anterior teeth by taking anchorage from the posterior teeth. So you can leave a comment in the comment section. This is finally the lateral ceph. And yes, the success of an orthodontist comes once we have a follow-up of the case. Once we see the follow-up after 2 years, 5 years, and 10 years, and we see, yes, the results which we attained at the time of debonding is the same after 5 and 10 years, it makes a person happy. It makes an orthodontist happy, and it is the patient who is being benefited the most by these type of treatments. So the second video will be uploaded soon after this video. So stay tuned with Dr. Junaid for more videos like this, and let me know what you think in the comments below. Assalamu alaikum.